Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on mentors and motivators who are consistently reshaping, redefining, and rediscovering the field of medical healthcare. I am excited to welcome Dr. Peter Attia, a physician, researcher, and renowned lecturer known for his findings surrounding the science of longevity and optimal performance. Welcome to Redefining Medicine. We have the esteemed privilege of having Dr. Peter Attia as our guest today, one of the foremost experts on longevity. Thank you so much for sharing your time.
Sure, thanks for having me.
So let's go back a little bit and talk about your interest in medicine. I know you have quite the extensive educational background. So did you always have an interest in going into medicine?
No, not at all. It was a very last minute change of heart. I studied engineering and math in college, so I was planning to do aerospace engineering in graduate school.
So what led to the change of your trajectory?
I think a number of things that I had just experienced personally when I was in college that sort of shifted my focus to not just doing something in science or something that was technical, which I enjoyed, but doing something that had those features, but also involved a little bit of an interaction with people.
So you earned your MD from Stanford.
Mm-hmm.
Slacker.
I was a bit of a slacker.
Okay.
Stanford's a pretty easy medical school. People shouldn't read too much into that. It was pass-fail.
Oh my goodness. And actually, going back to your undergraduate, so is it true that you helped design the curriculum for their calculus program? Yeah,
there were a group of 3 or 4 of us who were kind of the little whippersnappers in the math department. And this was a period of time when they were really revamping how calculus would be taught. So there was a consortium led by Harvard that came out with this idea that said every problem in calculus should be solvable graphically, algebraically, numerically. And this became a way that it was taught. And so I got to be one of the students that got to work on rewriting the textbook, and then I would go on to TA that class for 4 years, which I loved. I mean, I really miss teaching calculus. I can't wait until my daughter is old enough. She's already, she's 10, and she's heard me talk about it, and she's like, I want to learn calculus. And I was like, all right, well, you got to learn a few things first, right, but you're going to get there.
Oh, that's great. I hear she's quite the whippersnapper on the drums too.
She's a great little drummer, yeah.
Okay, so let's go back to you a little bit. So what sparked your interest, and I guess maybe it had to do with calculus. What sparked your interest in longevity and pursuing, research on that and finding the answers and the why?
I think it was just the realization of my own mortality. I mean, when I was 35, my daughter was born, and I guess anybody who's a parent probably goes through the exact same thing, which is and especially I think for men it's more than women, because I think women get 9 months to prepare for a new person coming along, but I think for guys it's sort of like you're not really understanding what the significance is, but then the second you see this little thing that to no other human in the world looks cute but you, because the second they're born they're not particularly cute, but to you they're really cute. And that was, I think, like a real switch flipped in my mind, which was all this other stuff I'm obsessed with, like, performance related or things like that, that's just less interesting to me than how long can I be alive to enjoy this. So even though it wasn't, I describe it now like it was a flip of a switch, it wasn't, but that's when the ship started to turn. And that's what, piqued my curiosity was, purely just for selfish reasons. I just wanted to, know how to live longer.
So how did that change? How did that epiphany change how you practice medicine at that time?
Well, at the time I actually wasn't practicing medicine.
Okay.
Yeah, so it didn't have any impact on my practice of medicine, and for the, entirety of my it's complicated because I had left medicine in 2006. Olivia is born in 2008. I didn't really come back to even scientific research until 2012. 2012, and I didn't really start practicing again until probably 2014. So by the time I revisited the practice of medicine, I had already, thought long and hard about these problems. So it wasn't, I didn't have to deal with the discomfort or the disconnect of in a moment changing the way I thought about something. I had a lot of time for it to percolate.
And when you left practicing in 2006, correct?
Yep.
Why did you leave at that point?
I was super frustrated with medicine, and I just decided I didn't want to do it anymore. And
what in particular? We hear it a lot, so I'm just trying to get to see what your insights were at that time.
There were lots of things. One of them was the patients that we operated on. I trained in surgery.
Right.
A lot of what we were doing was heroic, was amazing, but it was too little too late. So I just found that frustrating. I didn't know how to articulate what could have been done or should have been done. In other words, I didn't have a solution to the problem, but I was able to sort of look at this and think, this is frustrating to me. And then there were other just more petty sort of structural problems that I saw in residency that really bothered me. It bothered me that medicine didn't really strike me as a meritocracy. And
do you ever have any regrets for following your medical school path?
Meaning, do I regret that I didn't stay with engineering or something?
With engineering or doing something else, going for your PhD or what have you?
I don't know. I don't really spend a lot of time thinking about that because it's not actionable. I sort of believe in chaotic systems, and it's sort of amazing that I'm doing anything that I'm doing, but of course any given path can lead you anywhere. So
take us to how you practice medicine today and your desire to educate the difference between health span and lifespan and how that's implemented in your practice and your personal life.
Boy, that's a lot of questions.
Sorry.
No, it's okay. So I practice today trying to take an idea, a framework of how to extend life and improve health span, and then trying to figure out how do you apply that to a person, to a particular person, because there's challenges associated with that because, one, each person comes in with a different sort of genetic template or a different set of predispositions. Each person has been in a different environment. So if, let's say, someone comes to you and they're 40, they've been exposed to something, for the first 40 years of their life. And then they come in with basically a different appetite for how much they want something. The challenge with longevity, there are many challenges, but one of them is it's not an immediate payoff. So it's one thing to say, I want to learn to play the piano, or I want to learn to play tennis. Okay, well, if you want to do that, you get a tennis coach or you get a piano teacher, and you will go through a fundamental set of skills, and you will build and you will build and you will build, but you will get feedback in relatively short space. You will get feedback that, within days, weeks, months, you're seeing the benefits of what you're doing. And for some people, that gets reinforced, right? So like we're talking about my daughter. She wanted to start playing drums when she was 5, and from the first time she ever banged on a set of drums, she was just loved it. And within short periods of time, it wasn't just, boom, 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 and then she could learn to paradiddle and do X, Y, and Z. And now that she can play music, that's rewarding, and that reinforces the work you're doing. With some aspects of longevity, that doesn't happen. With some it does, right? So some of the things that improve health span, the things that you feel, a sharper mind, fewer aches and pains in your body, ability to do things physically that you couldn't do before, those things are reinforcing. But some of the other stuff, like reducing your risk of cancer and reducing your risk of atherosclerosis and taking the steps necessary to inch and claw away at that, you don't really feel those. And if you do, it's just not significant enough in my experience to really motivate people. So the challenge is figuring out how someone can be internally motivated by what it is that, because by definition, you're going to have to do something different from what is the standard thing that we would all just do if we were left to our druthers. I would just eat hamburgers and French fries and pizza all day, probably if it didn't matter what you did, I would just eat those things all day. So to make that sacrifice, there has to be something that you anchor to. And I think that's sort of the softer part of medicine, but it's like you sort of have to figure that out.
So who is your typical patient? Or are they already wired, should I say, emotionally to want to be compliant and make the necessary changes?
Probably more so than the average person, yeah, I would say so. Most of my patients are generally quite healthy. They're not, I'm not a primary care doctor. I'm not, which is not to say that I can't manage some of the issues like blood pressure or things like that, but that's, I'm trying to think of something in a slightly broader context. So, yeah, they're generally people who are either, quite young and quite healthy, but know that they want to, this really matters to them, and they've sort of figured out something that is true, which is the earlier you start, the bigger impact you can have. And then conversely, there's probably a subset of people who are now remembering what it used to feel like to be okay. So in other words, they've crested that hill, and they're coming down and they're thinking, gosh, it's not like what it was 10 years ago or 15 years ago, and they are now asking the question, can I get that back?
So in your keynote presentation, you talked about the difference between health span and lifespan, but can you speak to your philosophy of what the three most important elements are?
Of health span specifically?
Yes, of health span. And you also said in your talk that it's not about the incremental changes that you make, and people ask you, about diet and exercise and all this stuff. You talked about you need to find out the why, not the how.
Yeah, so I think the strategy for how you do something has to precede the tactics. So
Okay.
the why you do something needs to precede the what am I supposed to do. And so we're generally pretty wired to think about tactics. Again, you could rattle off an infinite number of problems people want to solve, but you take something like gun violence, and someone would say, well, how can we reduce it? And the first thing you'll hear anybody say, because again, I don't think anybody, this isn't a political issue, right? Like nobody wants more gun violence. So if you ask the question, what do you need to do? People start throwing out tactics, right? Well, you need to have, limit the sale of this type of gun, or, make sure you do a background check, or X, Y, and Z. And it's like, okay, irrespective of whether those are good or bad ideas, let's take a step back. What is the strategy, right? So I think that discussion seems to be missing from that, because those tactics, when they're sort of talked about, when they're bombarded at the problem, you don't get a sense of what the broader picture is, right? So again, gun control is probably a bad example because I don't know anything about it, but a strategy presumably is to reduce the number of the type of firearms that could be used. A second strategy would be reduce the number of people who would be at risk to do something wrong, blah, blah, blah. You'd sort of rattle off a whole bunch of things. And then the ideas, the very specific tactical things, would sort of serve a broader purpose of looking at each of those.
Well, let's try to equate this to the practitioner.
Depending on the type of practice a physician is in, I don't think most doctors have the time to go into the level of detail that would be necessary, or the resources within the practice to help with the implementation of a lot of these things. All of those tactical things that people want to talk about, in the end, most of them are things that require a modification of behavior. And so if you're asking someone to modify a behavior, it's important that you understand how to motivate them to do that. It's hard enough to get somebody to take a pill for their blood pressure every day, and that's about the easiest behavior there is, and yet the compliance is probably 70%. So if people are only 70% able to take a single pill for blood pressure once a day, and again, I'm making that number up, but that is directionally correct, how much harder is it if you say, don't eat all of these things, eat all of these things? So there's an entire discipline around trying to understand that, which, by the way, I don't think I know anything about, but I'm fascinated by it because and this was alluded to in the panel discussion, but you don't want to confuse efficacy and effectiveness. Efficacy is how well does a treatment work when it is administered perfectly. Effectiveness is how easy is it to administer this treatment in the real world over time. And So you always have to start with the question of efficacy. If you want to know how does something work when it's applied perfectly, and that's what you can do in a lab. But in the end, you have to make this leap when it comes to patients, which is they're not research subjects, and so it matters greatly what they can and can't do. And that's why, for example, tools such as time-restricted feeding can increase compliance. It might be why someone might find a fasting mimicking diet easier than just a water-only fast. And if the choice is, so I don't find the debate that interesting between, is fasting versus time-restricted feeding, is one more valuable than the other? I find that interesting at a personal level, but I think at a sort of societal level, the bigger question is, if you're debating both of those relative to just eating the, standard American diet, you're wasting your time. Have the patient do the one that is easier to do. And some patients actually find water-only fasting much easier. I certainly do. I find it much easier to eat nothing for periods of time than to eat very little, but others don't. So again, why, splitting hairs on that is the wrong, folks, that's majoring in the minor and minoring in the major. You never want to do that.
You had quoted, what is the secret to longevity is picking the right parents. Can you elaborate on that?
Yeah, and I wish I could remember, I think it was Nir Barzilai who said that, but the secret to longevity is picking the right parents. I mean, that's basically a way of saying that most of the extreme examples of longevity seem to be so tightly wound with genetics that although genes seem to play a very little role in people living to normal periods of time, whether you're going to live to 80 or 85, I can't predict that whatsoever from your parents, but people who become centenarians or supercentenarians, that nothing seems to be driving that further than their genes. Which doesn't mean that we shouldn't have hope, because we can learn from what those genes do and try to mimic that.
So somebody who is in their early 40s, for example, who up until this point in time ate the traditional American diet, exercised a few days a week, their parents are still living, so maybe they're in their late 60s, mid 70s, what have you. Their grandparents might still be alive, who knows. What are some of the, incremental or small changes that they should be making in their life to try to promote their own longevity?
It's really hard to know, because you sort of want to start with the one that matters most depending on where they are. So for some people in that situation, maybe you realize that their sleep is really bad. And until you fix that, focusing your effort and energy on these other things is a slightly diminished return. For other people in that situation, the one you gave, you were sort of specific, but for some people in that broad category, it's simply movement. If they're 40 and they're already showing wear and tear and signs of injury, and their back is already hurting, then I'm sort of thinking of that as the biggest issue you have to be afraid of. So when you're looking at someone who's 40, what you should be asking yourself is not what is the next problem that's going to hit them in a week or a month. You should be thinking about what is the iceberg that they're going to hit in 40 years. And if someone's consistently having back pain and they're 40, it doesn't really matter to me if they're going to get cancer at 70 versus 80, because they might be so debilitated and in so much pain that becomes a higher priority, which is not to say you won't later take steps to reduce their risk of cancer. But in that moment, the most pressing issue is fixing their movement or their sleep or whatever the issue is.
You had talked about the concept of mind, body, spirit. You hear that a lot, but what does that mean to you?
Yeah, I have kind of a clinical definition of some of these things. For me, mind is cognition, which has these three things that we can measure pretty well: processing speed, short-term memory, and executive function. Body, I also have pretty specific things I care about there with respect to muscle mass, range of motion or functional movement, stability, as probably even more important than mobility. And then different types of performance as well. So kind of what I would think of as sort of mitochondrial performance or aerobic efficiency, and then anaerobic capacity, freedom from pain. So all of the sexual function, frankly. Everything that the body does is sort of a part of body. And then spirit, for me, probably comes down to happiness, which is not something I am an expert in at all, or particularly spend a lot of time necessarily even in that state sometimes. But that includes sort of that seems to be made up of a sense of having a sense of purpose, having a social support system, having the ability to cope with distress. So I think for everybody those things are a little bit different. For me, I'm an introvert, so I don't like being around a lot of people. But if you play a thought experiment and take that to its extension, if you told me I could have everything that my heart desires, but I was stranded on a desert island by myself, that also would be torture, So when I play these experiments, I start to figure out what are the things that really matter to me by playing really extreme games like that, and I start to realize, okay, really for me, nothing in terms of happiness seems to be more important than my relationships with a few people who really matter to me. So it's one of those things where people have to figure out what makes them happy, and I don't think it's really anyone's place to sort of extrapolate from one to another, or from my view to theirs. So if you don't have those three things, that sort of, as you called it, mind, body, spirit, to some extent, the rest of this doesn't matter that much, because for most of us, and there are exceptions, of course, but for most of us, losing one of those makes it a lot less sort of palatable to stick around. But again, we know lots of notable exceptions. There are people who completely lose their body, but they're able to find a new happiness in something else, and so their mind is fine, their spirit is fine, but their body's not, and they still live a totally fulfilling life. So again,
is one more important than the other?
I don't think so. I mean, it depends. I mean, the obvious point is when someone loses their mind, they cease to be aware of it, we assume. We don't know this, but the assumption would be that when someone is in the late stages of dementia, we don't know what that means to them, but virtually every human being, when in a perfectly normal cognitive state, is asked, would you ever want to be in that state? The answer is no, and the answer is usually no because they don't want to be a burden to their loved ones, even though they know that they won't really be suffering in that state.
Right. You had talked about stress, and when I think about stress, I think of it as affecting all three of that, mind, body, spirit.
Yeah, it does.
And you said it's not the stress that is the problem. Everybody has stress. It's the coping mechanisms and how resilient you are and whatnot. Can you discuss that?
Yeah, I mean, I think that hypercortisolemia is probably the easiest and most sort of biochemically easiest pathway to explain. But when cortisol levels are elevated, and again, cortisol, like all hormones, we sort of tend to view these things as binary, they're good or they're bad, but in excess, it's bad, just as if you have a deficiency of it, it's bad. But if you have excessive levels of cortisol, it's doing bad things across the body. It's doing bad things to the endothelium, it's doing bad things to sort of your system of glucose disposal. It's doing bad things within the brain. It's suppressing, the release of melatonin at night. So not uncommon for people who aren't sleeping well to see at the root of it, it's, some form of rumination or, manifestation of distress that is showing up in hypercortisolemia. So yeah, it absolutely affects all of these things. And unfortunately, these are the harder things to fix. I mean, in some ways it's easier to, if a person is really willing to change the way they eat or the way they exercise, those actually are easier to put in place, but it can be quite difficult to make, to teach a patient and work with a patient, or to make the changes that can reduce the negative response, or the, I guess a better way to describe it would be the habituated response to stress.
To me, consciously, I can think about the fact of, how I'm going to manage a stressful situation, and it would have a positive effect, like I would, be mindful of it and whatnot, and so my spirit would benefit from it. But internally, it's still affecting your mind and your body.
Yeah, I mean, different people have different ways of, there are some people who internalize stress and it's unhealthy. There are others for whom internalizing it the way people describe it that way is actually quite beneficial, because it prevents a negative outward behavior or action that itself is quite disruptive or destructive and destructive and ultimately leads to kind of a worse state.
Do you think that there's one most important ritual or what have you that you have implemented into your life that you would be able to recommend people in order to, live at least, a more fulfilling life?
I get asked this question
longevity?
all the time, and I wish I had a great answer. I don't. There really isn't one thing. The good news is there are lots of things that can make that difference. And some people are just wired differently to respond to some of these better. So for some people, exercise moves the needle more than anything else. For some people, fixing their nutrition moves the needle more than anything else. And fixing their nutrition is obviously a much more complicated statement than just that. So I don't have a great answer. For some people, the practice of meditation, has a greater impact on their life than anything else.
Do you meditate?
I do.
Every morning or certain times of the day?
I usually try to in the mornings, but sometimes I don't.
So what modalities or protocols have you implemented into your life to try to increase your longevity? And how often do you check certain genetic markers and things to see?
Well, all of those sort of 5 things that I've talked about as the tactics or the tools, changing nutrition, implementing a certain program around exercise, sleep, et cetera. I participate in all of those things. So I'm doing every one of those things. And some of those things you can measure the progress in. Some of those things are very easy to measure progress in. For example, the progression of atherosclerosis is very easy to measure using advanced tests in the lab and even imaging studies if you feel so inclined, although I feel like those probably ought to be used sparingly. Other things are much harder to measure your progress against. Cancer, for example, your risk of cancer is very difficult to measure your progress towards. So much of what drives cancer is really out of our limits of measurement and detection. Some things are. So, not having hyperinsulinemia, for example, would reduce your risk of cancer, but not to 0. So therefore, you can never know for certain with some of these things. Similarly with Alzheimer's disease, Richard Isaacson has done great work on this topic, looking at ways to reduce risk in high-risk individuals. And so many of these are completely quantifiable. So I participate in the measurement of everything that is quantifiable, but that still falls short because there's still things I can't measure that I wish I could.
Are there certain technologies that are coming down the pike that you're excited about that would help to increase longevity?
Well, there are certain technologies that are around today that are only getting better. To pick one example, I think continuous glucose monitoring, which I've been using for over 3 years, is, it's just hard to imagine not having that tool. And, I think in the past year, the device that I use has taken a big step forward in terms of its accuracy and its ease of use. And so I would say that in 2 years, 3 years, when it gets even easier, you'll see more potentially widespread adoption of these things. They're a fantastic behavioral tool because for most people, they just don't want to see right in front of them the effect of what happened when they ate that plate of fries or whatever your want is. So I just find having the continuous glucose monitor, 1, it provides me insights that I can then use to modify behaviors, but 2, it acts as a Hawthorne effect, which we know when you're watching people, they modify their behavior. And this is basically a self-ability to watch myself. So that's an example of a technology that I think almost without exception, anybody who wears one of these has improved glycemic control, ranging from people with diabetes to people without.
You have a 10-year-old, so I'm sure you can appreciate this, and you live in San Diego, but I can just go to Disney World or Disneyland and have that same effect because you see everybody's walking around at 300 pounds and they're stuffing their faces with their giant turkey legs and the fries and the cotton candies and whatnot, and I just said, okay, that's it, I don't need it.
And that's great for many people. Like for me, I would experience that for the day I was at Disneyland, but I could probably forget it by the next day.
The image just won't leave my mind.
Yeah.
what is your hope? What would you envision the future healthcare system looks like that would help to or enable people to live longer, healthier lives?
Well, I mean, one of the things that I think a lot about, and I talked about it briefly in the talk, is I think that right now there's a bit of a disconnect between what patients are looking for and the doctors that are right in front of them. And for example, when I was walking here, a woman came up to me and said, she introduced herself and said, I have a practice just like yours and I'm in San Diego. And I was like, that's fantastic, because I get asked all the time, Peter, are there any other, because I'm not really taking new patients. And she said, are there, and I've always said in San Diego, I'm sorry, I don't know anybody. And so she introduced herself, and that was great. And so with the podcast, what we're doing is creating a database for doctors. And it's actually going to be global, though I suspect most of the physicians and physician extenders, right? So it's, NPs, RDs, et cetera, will mostly be in North America, but we've already got people coming in from outside of North America. And the idea was, create a template that is not so burdensome that no one will do it, but there's enough effort that you're filtering out people who aren't serious about why they practice the way they practice and why they think the way they think. And we're not looking for a bunch of homologs, meaning we're not trying to replicate anyone, including me. The question is, could you create a template that allows a whole bunch of providers to say, this is what I focus on, this is what I care about, this is my philosophy of medicine, which I think is a very important question. I don't think enough people can answer that question. What is my philosophy? How do I think about this? There's no right philosophy, but if I'm going to come and see you, I should know your philosophy and you should know mine. How much time do you spend reading this type of material, that type of material? And so my hope is that this physician database, or whatever we're calling it, will be something that in a period of time, it has to hit a critical mass, but in a period of time will be an amazing resource for patients to be able to put in their zip code and say, okay, well look, there's 6 people within 10 miles of me, and now I have the chance to pick sort of the right one. So it sounds crazy, but it's sort of like this matchmaker role, I think, is really important. And when I realized it didn't exist, when I kept getting asked the question, I live in St. Louis,
right.
Who can I see?
But that seems like it works in a concierge practice.
No, not at all. Lots of people,
okay.
Lots of primary care doctors think the same way, or in derivatives of how people would be thinking here. So, and in fact, that's sort of one of the questions you would actually want to know if you're a patient is, do you take insurance? I mean, that's the second question we ask after what's your name or something like that, right? I don't think it's really about whether a doctor takes insurance or not. I think it's much more about, as soft as it sounds, what is their philosophy on this stuff? How do they think about prevention? Because that word has lost a lot of its meaning. It's a buzzword, and everybody says they care about prevention. But if you really care about prevention, you have to start acting before a problem shows up, not reacting to a problem after it's shown up.
But I think the education for these physicians needs to change during those first 4 years and subsequent years, because
absolutely.
They're not taught prevention.
That's right.
So, like yourself, you figured it out after the fact that you knew the system was broken. And, in an A4M community, you have 5,000 physicians who feel the same way you do. But there's, how many thousands of physicians are being trained every year and starting medical school with this altruistic, wonderful, I want to save the world, save the planet, save every human being's life. And then they get out and say, wait a minute, I can't put a Band-Aid on and save anybody.
Yeah, you're correct. It really is a process of re-education. So the first, as soon as people come to that realization, which is there's tremendous value in medical school, no one's suggesting that you don't continue this process, but the most important thing that they should be teaching in medical school is critical thought and how to constantly update your information and your insights. Because that's the only thing that's certain when you finish medical school, is that whatever you believe to be true then will probably not be true to the same extent down the line, and certainly not for the remainder of your career. So yes, it goes without saying that if you want to practice the way that I like to practice or the way that people here like to practice, you just have to adopt a mindset of constantly learning. And that's why, for example, in this template, we spend so much of the template is really breaking down how many hours a month do you spend reading the literature on this topic or this topic or this topic, or going to these conferences or these conferences. Because I think that's at least a way for patients to get a sense of, okay, you know, that's the kind of person that's probably aligned with me. Now, you know, in the end, I think, you know, everyone talks about the healthcare system in the United States being broken. To fix it is, you know, that's just well beyond my scope of understanding, because there are, you know, two other legs to this stool that we don't talk about that much on the medical side, but that's sort of cost and access. So we talk about quality. So the only thing I would say on that is it's impossible to fix one without adjusting the others. The three are tethered.
Let's hope in 5 years we'll change the conversation.
Yeah.
Thank you for your time, Dr. Attia.
Yeah, thanks so much for having me.